Thank you all so much for coming. Welcome to our community of practice, our assisted outpatient treatment community of practice. I'm going to do a little bit longer of an introduction today because I see a lot of new faces here and a lot of new, a lot of new people joining us. So again, welcome to our community of practice. We have been holding this space for a little over 2 years now to basically convene professionals from all across the state to talk about AOT processes and tackle different barriers and things that come up in this work. So this started primarily targeting the target audience being community mental health providers and staff, but we're finding that a lot of the subject matter is applicable to a lot of different audiences. So again, welcome. I want to also mention that we do have folks from all across the state here, whether you are from a urban metro or rural county, wherever you are in the AOT process, the subject matter, can sometimes you can, listen to it and it'd be like, oh, this might not be applicable to me. This is not where I am, in the AOT process. That's completely fine. You're not the only one who may feel that way or be in that position in this call. But, when we do get to that Q&A session, feel free to really ask questions and really give your experience, because when it comes to AOT and AOT processes and program and really getting our practices in place, we are all on different levels of that spectrum. So don't feel like you're the only one if you may not have what you need to execute a lot of these different practices we may talk about. So yeah, just ask questions and we'll go ahead and get started. I do also want to always plug our Q&A sessions. In case you don't know, we hold twice monthly Q&A sessions where we have Dr. Scott Smith available to answer any AOT related question. It operates very much like an office hours. It's not something you have to come on time to, but there is an hour span where you can just come anytime. And whether you have, a question about a specific case or something that you want, somebody to help you brainstorm, an expert, Dr. Scott Smith is available during those times. So I will go ahead and drop those in the chat. Next month, they're going to be Monday, March 9th from 11 to 12 p.m. and then Wednesday, March 18th from 2 to 3 p.m. That is the second Monday of the month, and the third Wednesday of the month is when those are held. So if you have any lingering questions from today that you don't get answered, feel free to attend those. Or that can be a really good resource to give to individuals or natural supports of folks who are on AOT orders, because they are, that's just a good resource for having access to an expert. So before we go ahead and jump into our presentation, I did send out, if you are on our calendar invite and our email list, you should have gotten, a reminder email. And in that reminder email, there was an AOT in Jails one-pager. So we had, created that as kind of like preliminary information to this community of practice event. So I see that Jenny went ahead and put that in the chat. So go ahead and, give that a peek if you'd like. It gives maybe a brief overview of a couple of the things we may be talking about here today, different barriers in working within the jails, and, a couple identified best practices. So on that note, I'll go ahead and turn it over to our presenters today. It's Christy Granger and Anna Bashore from Clinton, Eaton, Ingham, CMH. Christy, if you want to go ahead and take it away, thank you so much.
Yes. Hey, everyone. Welcome. I do want to call out my help here today, Anna. I just want to share that my role at Community Mental Health is I oversee what's called our Court and Community Liaison Team. Anna specifically is one of our identified crisis services therapists within our jail setting. And both Anna and I work very closely each day on navigating specific cases. I did want to plug what Olivia said, that this isn't a standard. like Olivia said, each county, each facility operates different. And so we're going to, this is just a practice that has worked for us that we're finding that is successful. It is not foolproof by any stretch. So I just want to make that clear. So we can go on to the next slide. We're going to talk about what does it look like to navigate this. And most of you know, but I have to give a big plug for my Wayne State folks about their identification of the AOT process. And I think it's really important. Folks get confused that it's just an outpatient program. Assisted outpatient just refers to different types of orders. So we have the assisted outpatient order, which only focuses on treatment on the outside in the outpatient realm. Then we do have combined orders. We have straight hospital orders. What we're really going to focus on today, Anna and I, are actually some combined orders and how we do it without sending them to the hospital. And we're going to talk about that and why we do it in this structure versus why we don't do straight AOT. So we can go on ahead. So really, what is the goal? Our goal in the jail is to prevent some recidivism, continuity of care, hopefully some cost savings, and overall public safety if folks are getting the treatment that they need. Next slide. So as we said, we want to reduce the recidivism. We want to reduce the cycle of arrest for those that have a significant mental health history or illness. We also want to assume a seamless transition from the jail to community. And this is something that Anna and I work very closely on. And this is probably the thing that our program focuses the most on, is how do we ensure if someone is in the jail, what are we going to do to make sure that when they are released out into the community, how do we get them to CMH? How do we get them to treatment? And so we'll talk about that. Also, we want to, we look at, how can we improve safety by getting folks treatment. If we get them their treatment that they need, the hope is, right, is that they're not having these situations in which maybe they're homeless and they're struggling with significant depression or psychosis, and a voice tells them, you need to go into this restaurant and, you need to eat, and there's people there and they're scared, and then escalation happens, those types of things. So really working to improve on that community safety. And then of course, the big thing everyone wants, the cost savings, the less visits to the ER, this cost associated with court, and potential homelessness. Next slide. So how do we accomplish that? Here with our tri-county areas, I want to be clear, Anna is our representative in our Ingham County Jail. We do service three jails. We have our Clinton County Jail, Ingham County, and Eaton. We at CMH have representatives that are CMH employees in each jail setting. However, our Ingham County program is the strongest at this point. So that's what program we're focusing on. So it does require an entire team. And so with our program, we do involve our judges. We're involving the legal counsel. We also involve our jail administrator, and we have dedicated liaisons from our jail. So that's what I'm talking about, is like what Anna's position is. So Anna is the therapist within the jail, but she is our liaison. And so we have that direct communication so that we're not losing and figuring out each day, well, which provider is going to be there? And oh, should we reach out to this person, or who's the next one? So how we've been successful is even at our prosecutor's office, we have an identified liaison so that the same people are involved in this process and know what to expect. And so we'll talk about that. Next slide. So, like I said, who's part of our team? Of course, our consumer. We call our jail staff CATS staff, and Anna will talk about what that stands for. Our court team, our CMH psychiatrist, our prosecutor, defense attorney, judge, and for us, our public defender's office. We now, in our public defender's office, we have 2 to 3 social workers that are working within our public defender's office who are also part of this program and are reaching out as a referral source for individuals. Go ahead. So we want to talk about how do we get these referrals? How do we know? All these folks come into jail, they're struggling. How do we know to work with them? So we have a system in place right now, and we can talk a little bit more about this. But our probate court has set a system up where what happens is we often have family members. So someone gets arrested, and oftentimes they may be in a mental health crisis, or family just doesn't want them in jail. And so what do? They go to the probate court and they'll fill out a petition. Well, as the court goes through it, they're like, oh, well, your person's in jail. Like, they don't seem to be at a risk right now. Can you tell me more about it? And what happens is individuals who present to our Ingham County probate court and they note that they are in jail, they reach out before they will sign the petition. They reach out to either Anna or myself, and they will say that the court will say, hey, is so and so in the jail? Can you please provide an assessment and get back to us? And Anna will talk about that, where the judge will say, we're not going to issue this petition. We're not going to issue a pickup order. We're not going to issue an order for transport and avail until we get feedback from the therapist. And that's where Anna comes in and will provide that assessment. And then we'll report back to an email form to the team. And then if Anna's like, yeah, I think it would benefit, or yeah, we'll go ahead and do that. Also, we get it from some of our judges. So what often happens is, like say our city jail, an individual is arrested, they're at their arraignment, the jail staff or the judge is saying, something isn't feeling right about this situation. We are very concerned. This person appears to be in a crisis. That judge will email us and say, hey, individuals here, we're arraigning them and they are going to be sent over to county. We need them to be assessed. And then that's where I start and consult with Anna. I said, okay, so-and-so is on their way out to county. This is the requirement. We need them assessed. And then Anna's team will report back. We also might get a referral from the public defender's office where they'll say, you know what? Johnny has been arrested 6 times this month. Nothing is working. Something seems to be going on with their mental status. Can CATS look at him and report back? Or the CATS staff may see someone in the jail. I might have someone we've been looking for that hasn't connected in the jail. So say we have someone who may has been placed on a court order already in AOT, but we can't connect with them. We can't find them anywhere. And so we're working with the CATS program to locate that, like if they're in the jail, and consult with them and make some decisions. And we'll talk a lot more about all of this. Or we might have a referral from the emergency room staff saying, hey, Johnny came in, he had warrants, he went on to jail, but there's a mental health concern. Can you guys take a look at this? Next slide. So I want to turn it over to Anna, where Anna's going to talk about like the CATS, the Crisis Services Department, what those assessments look like, and how we determine if AOT may be an option. We're not deciding if they're placed on AOT. Ultimately, that's the judge. But she's going to talk about how we do the assessment, how we consult, and then how we make those decisions going forward. So Anna, if you want to take that over.
Thank you. Like Christy said, my name is Anna Bashore. I am one of the crisis workers here in the Ingham County Jail. And so Christy and I, like she said, work very close together. I would say we talk almost every day. So one of the things that has been very helpful is the chance to do these assessments before the petition is in place, before the AOT kind of gets rolling, because it gives us a chance to really assess the person after they come into jail. There's many times where people are coming into jail and a family is maybe petitioning them due to concerns, and it turns out that those concerns may be related more to like substance abuse, or maybe some behavioral things. They didn't want to be in jail. So having that opportunity to assess these people after being in jail has been really helpful. So the AOT process, when someone comes in, like Christy said, I will do the assessment, and then we will see if there is a need for AOT. Basically, a lot of times we won't petition people from jail, just because the criteria is a bit higher for those in jail. So the AOT helps us with that transition from jail to the community. It has been a struggle in the past to find any psychiatrists that are available. I know Christy's been kind of working on something that might make that a little bit easier. So back to the process. So they reach out, I will meet with the person, see if they need to be on an AOT. Most of the time I would fill out the paperwork, and then we would meet with the psychiatrist to go through with that process. The lawyer will reach out to the client while they're in jail and talk to them about the process, and then they will have a set date where they will meet with their attorney and lawyer, and judge to kind of talk about that process more. I feel like I'm missing quite a bit, Chrissy. Is there anything else that you want me to?
No, and I think, yeah, nope, I think you're good. I see their question whether the diversion or
Yeah.
the AOT. And so where I want to pick up is yeah, there's a bit of diversion, but we do have where we get this and where we start in with the AOT and what Anna's talking about is that the initial assessment. So she's doing that initial assessment, and if this person is identified as someone who would benefit from AOT, what's then happening is the team is coming together to talk about how we're going to process that. And as we know, the barrier to AOT only is that a psychiatrist is the only one that can complete a clinical cert for AOT only, which can be a barrier, especially in a jail, because they might be staffed medically by a nurse practitioner, or they contract with a physician or whatever they may have. So that becomes a barrier. And so what we have developed is what we often do is what we call the combined AOT with no upfront hospital. So Anna will do that assessment. She will reach out and she will say, hey, you know what, this person really does meet the criteria for an AOT. I don't really think they need to go to the hospital. So the treatment team will go ahead and discuss who's going to do that petition, often the jail. Then she will reach out to me and she will send those petitions our way. We then have our crisis services department here, because we have a freestanding crisis services department at CMH 24/7. We then coordinate with our psychologist on staff, who will then conduct a Zoom assessment within the jail to determine if a first cert is appropriate. At that point, if she identifies the first cert or does the first cert, we then have slots where we have 3 psychiatrists that work on our court team. So each week on Mondays, they are working with our consumers. That one week they're doing the cert, second week, they're going to court. So if we get that first cert, then we're getting that second cert by the psychiatrist, and then we might present and go to court and just ask for combined order with 0 upfront hospital days. If we just have the psychiatrist available, we are able to do the AOT in the same process. So what we do is we will have the petition completed. Anna will reach out to us. We will go ahead, because if it's an AOT only, you have the 28 days to secure that evaluation. So we're putting them in our psychiatrist schedule. Our psychiatrist, all of this is done via Zoom while in the jail. So our CATS program is coordinating all those assessments, and then all of the service, everything that needs to happen. So once you fill out the petition, you get your cert by your psychiatrist within the 28 days. And then these individuals need to be served. All of that is happening within the jail. And then we are also coordinating. We have the court-appointed attorney who is also meeting with them in the jail over Zoom. So we have a process for that. And then each of these individuals are able to attend their court hearing for their probate order while in the jail. And like I said, that is all happening over Zoom. Next slide. So, that's the biggest thing. And why do we do that? What is our plan? So what we do is, if we are able to get an individual on the AOT, that is our biggest focus right now. Yes, it's diversion, but many of these folks, especially, as you guys know, folks are being charged maybe with misdemeanors, and they're getting on a wait list to go to forensics, and it's taken months before they can get into forensics, and they're sitting in jail and they're not getting better. Like, what are we going to do to help this process? And that's where our jail program comes in. That's why we're doing this AOT process. We're completing these petitions, because the goal is if we can get them on the AOT while in jail, then we have a system in place. We're very fortunate. So say if someone gets on AOT, what happens is Anna's able to work with the jail administration, and we can see, like, Johnny's going to get out on Tuesday. It used to be that when Johnny got out on Tuesday, Johnny was released at 4 o'clock in the morning, right? And Johnny was released to the street, and then Johnny didn't have anywhere to go. And so another crime would happen. So now for the individuals that were able to get the AOT on, what happens then is we don't have those 4 a.m. discharges anymore. Our jail administration has agreed to, perfect, they're on AOT. Anna reaches out to the court team. The court team actually works to go pick the individuals up that are on AOT from the jail. Or if we know it's going to be after hours, what happens is the jail administration has agreed that they will bring them to CMH. Our goal with that is they go directly from the jail on AOT directly to CMH for an assessment for services. Okay, now, if that assessment, as we know, the assessment, we have walk-in assessments, and so our walk-in assessments are 8 to 3. Well, the jail doesn't always work like that. So say if an officer, if they're going to be discharged or released is the right word, at 6 o'clock at night, we have a system in place where Anna will say, hey, they're going to be released at 6. Officers will bring them. We have what's called an extended observation care bed, an EOC bed. We will put individuals on AOT in our crisis services, in a crisis services bed. It's just a place to be safe, connect, have their meals, so that at 8 a.m. they can go for their art assessment. Because the whole goal, like we said, is to get folks connected to treatment. And so we try to be very, very creative each case and how we're going to make that happen, so that we're not, yeah, it's great, wonderful, Christy and Anna, you got them on AOT and then they release to the community. No, that's not happening. They're releasing directly to CMH, or some of them maybe in a spot where they really are significantly decompensated. We're getting them right over to the emergency room, but we're connecting with our emergency room. We have a behavioral health liaison in our largest emergency room here in town. And so all of these people are part of our AOT team. And so we have regular meetings. We are discussing the consumers. We're discussing the frequent flyers and how are we going, to benefit them. Is an AOT a benefit? We're fortunate that our jail administration in Ingham County, the deputies, they get on Zoom calls with us. Our lieutenants, we come to the table with our public defender's office and we're like, Johnny's back again. What are we going to do? Is an AOT appropriate? What else is appropriate? So those things, it does sound like jail diversion in a lot of ways, and it is, right? AOT is supposed to be jail diversion, but it's how do we come together? Because the ultimate goal is you've got to get them either voluntarily, of course, cooperating, or on the assisted outpatient plan so that these things can happen. And honestly, it's not foolproof. We talk about this, but it has been successful. And the one thing we get, and I'm going to let Anna talk about, is great, you got them on AOT and say They're on AOT only, they're in the jail, and they're refusing medications. Well, what good is that? Some jails will, quote, force those medications. Others will not. And we know that that is an individualized county thing and everyone operates under their own. We do have a certain formulary where Anna can talk about that, like meds that they will administer. But the goal is, yes, is how can we get them the treatment in the jail and get them stabilized before they get out in the community. So Anna, if you want to talk about like your med clinic and the crisis services you guys offer, the groups that you offer in the jail, that'd be great.
Yeah. So like Christy said, we are so fortunate here in Ingham County that we have a lot of buy-ins from our jail admin and the deputies. It hasn't always been that way, but I feel like the CAT staff have worked really hard with the jail to kind of form that relationship. So there is a seamless transition from jail to CMH. So like Christy said, sometimes people are here on court orders and they're not doing services, they're not taking medications. So everything is really case by case. If the person is so ill that they're needing hospitalization, we'll go through with that process and fill out an O&C. If the person is able to be held safely here in the jail, we will most likely work with our psychiatrist here in the jail to get them on the list to see the psych doctor. We have a doctor who is in person on Wednesday and a different doctor who is via Zoom on Mondays, I believe. So people do get in to get medications pretty, I would say, faster than it has been in the past. So our goal really is to get someone enrolled in the CATS program. So it's a therapy program, a substance abuse and a mental health therapy program here within the Ingham County Jail. We have 3 mental health therapists. We have 3 substance use therapists. We have 2 peers, a community reentry worker, 2 case managers, and a client support specialist. So that's the CATS program within the jail. And so my job is to basically help clients become stable enough to be enrolled in that CATS program and have the therapy while they're here in jail. The medications is really, I guess, kind of a case by case. I spoke with medical this morning. They're willing to prescribe mostly anything, but it's definitely, like I said, a case to case. Most of our clients who come in on mental health medications are just going straight to the psych doctors. They don't really see jail medical for their medications, so it's mostly controlled by the doctors here, or the psych doctors. Did you want me to talk about anything else, Christy?
No, I think that's good. We're getting questions about, are these charges dropped? And we'll talk about that at the end. Next slide. Okay, we've talked about this. We can move on. So, what are the barriers? A lot of it is just the lack of education. Folks don't understand what AOT is. And so they're like, oh, just put them on AOT, just put them on AOT, but not understanding that AOT itself is, they want to know what CAT stands for, community, just 1 minute. So what is it? People don't, they're like, well, great, just put them on in a court order and put them in the hospital and be done. No, AOT is not like that. And that the whole concept of this assisted outpatient treatment is to get folks involved in treatment before they get to that crisis, right? But in Michigan, as we know, that that is a challenge in the sense that the way the law is currently written and the goal of keeping them out of the hospital is that the psychiatrist is absolutely the only one that can do that cert for AOT only. So it's really educating our community partners about that and finding ways to make that happen. The benefits, of course, there's lots. If we are successful in getting them the treatment, in doing that communication. So if we're able to get them on the AOT in the jail, and we're having direct communication with our community partners, and folks know that, hey, Johnny, oh, look, Johnny's on an AOT, remember? Then it's calling community mental health immediately instead of calling 911 because Johnny broke into 7-Eleven again. It's like, has Johnny been compliant with treatment? Has he not? Do we need to get Johnny picked up by the police and brought into the emergency room? And does Johnny just need a shot because he missed it? But he doesn't need to be charged with a crime because where's that going to get Johnny? So it's really a lot of coordination. And I know in a lot of my conversations, that's all that I harp on, but really that's it. Without community collaboration, none of the programs will exist. And it's a ton of work. And often there's a difference of opinion because of course everyone comes from a different perspective. But when you can come together and you talk about what ultimately is the goal for our consumers, whether they're in jail, whether they're in the homeless shelter, it's that stability. It's for them to live successful lives out in the community. So how do we do that? And oftentimes it has to be creative and it's not perfect. Next slide. So basically what I say is, how do you know if you're successful? I always say, I think of a case right now that it used to be every week that individual was in the jail. They're calling, he's back. He's back. So what does that look like? Well, for individuals, if we can get them on an AOT and they're cooperating, it may be that they're only coming in the jail once every 3 months versus every week. And we might be seeing increased compliance. They might be able to stay put in the shelter 60 days versus not at all. Reduction in harm to themselves, less psychiatric admissions, of course, less arrests and incarcerations, less visits to the ER. But it's really, like I said, it's that communication. So all of our folks in the Tri-County area are inputted into our database. And so we have a system where we at CMH know every single individual that is court ordered, like most programs. We have it pulled up. So like our CAT staff is CMH staff. So when they're coming into the jail, they're able to pull it up in our system to see if they're already on an AOT. What could we do different? Our emergency room staff has direct access to us. So they're able to call and say, hey, Johnny's back. Is Johnny on an AOT? If not, what should we do? So it's a lot of that. It's a lot of case consult. A lot of communication is happening. As far as the charges being dropped, the charges in this situation are not being dropped as of yet. We are exploring an AOT misdemeanor program and what that looks like. Meaning, is there a way to divert? So if an individual is coming into the jail, they've been charged with a misdemeanor at the district level. So say they're charged with a crime at the district level, and the judge is like, man, they just don't appear stable. I'm concerned about their competency. I'm concerned about them going, before proceeding with the court. We're hoping to have a referral process, more to come, and how those individuals will get referred on to the probate court to look at the AOT process and placing them on an AOT order only with help from our university to secure those evaluations. And then if they are placed on these AOT orders, and they are compliant and doing well for the 180 days, the duration of the assisted outpatient order only, then their charges would be potentially removed. There's a lot coming with that. There's legislation about that, more to come. But our current practice right now is no. These individuals placed on AOT, their charges are not dismissed. It's just another mechanism in place within our community to help individuals hopefully to become stable and to actually use less resources, right? And to be able to be productive and to remain housed. Next slide. So really, we really focus on, it's just a lot of communication, a lot of collaboration, a lot of connect, a lot of support, a lot of tension sometimes, as we talk about, officers jail deputies, mental health isn't their thing, right? And they're like, just get them out, put them in the state hospital. What are you doing? So it's a lot of that. A ton of communication, a lot of education. And we have found out within our CATS program that having these three crisis services therapists who are very well trained in the AOT process and education, being able to communicate that back to their deputies, you get a lot of, oh, that makes sense. And we're getting, how can we help? Like a couple of weeks ago, we had a sergeant get on and say, hey, this guy's been calling, like, what can we do? Like, could we do an AOT? Like, do we need to look at? And like this gentleman happened to be in a medical hospital. There was concern about some psychiatric stuff, and this sergeant wanted to know, like, what are we going to do? Like, how do we come together as community? Because he's going to keep coming back. And is he coming back because of a psychiatric need? Is he coming back because of an SUD need? So even though it may not always focus on AOT, there's parts of it that it does, and it's just bringing us, the entities, together to process, how are we going to help these individuals? So that's kind of our brief. I know it's quick, a lot of rambling, and I know there's probably a lot of questions. I wanted to wrap that up and open it up to questions or feedback or things that are working well for your programs or how we started. So that's what I got.
Great. Thank you so much, Christy. I really appreciate, even though it is, like you said, brief, and we could go into this a lot further, and this could be a 5-part series if we, if we really wanted it to be. And but thank you so much. I wanted, to also open it up and see if anybody had any questions about the presentation or about, AOT and jails. Otherwise, you could either come off mute or put it in the chat.
Hi, Christy. Hi, Anna. Thank you so much for sharing this with us. I'm actually really curious about what your community outreach and sort of buy-in process has looked like since you started until now. Because it seems like, as you said, you have a good amount of collaboration going on. And obviously there are people who have different opinions on things, but what has that looked like for you from inception until today?
Anna can interrupt, but I would say amazing, but a lot of work. It wasn't always like that. I would say in the last 1.5 to 2 years. It started, we are very fortunate in our county to have some amazing judges who are very vested in the mental health system and collaboration, and that has trickled down. We also, through a lot of challenges, have learned that where's the breakdown in the system, and typically the breakdown is that education and that communication. And so what we have found to be successful in our area is, you have these huge agencies and a case manager assigned here and a case manager assigned there, and then trying to go. We've taken that out of the picture, and that we have identified liaisons only. And so even at our court office there, our probate court has a liaison. That's the only person we're talking to. The jail has Anna's the liaison, our public defender. And so having that very specific communication thread, and then those people are reaching out to the others, but it really took time to identify that and figure out the barriers. So right now we're very successful. And as a result of that, we're doing some great things as far as the programs that the community really wants to take part in. Hope that answered it.
Yeah, I think that was a great question, and I know that comes up a lot in terms of AOT, and it makes me think of what Christy and I both said at the beginning of the event today is wherever you are in the AOT process, part of it is having that buy-in from other folks who you need to have relationships with in order for these processes and practices to work. So yeah, So I think that was a great question. And I'm glad we got to highlight that. So I had an, yeah, I had another, I guess, if anybody didn't have any questions, I was curious if anybody was reflecting on their own processes in terms of jails and how you work within your jails or with your jails and had any thought of any differences, or if anybody was in a position that was like, I am nowhere near this, I have no buy-in, I have and I'm curious if anybody would like to speak to their own experience and uh how they're trying to navigate that part of AOT.
I'll jump in here. I know that whenever this discussion comes up for us, we always kind of get hung up on how to administer medication in the jail involuntarily. And that's something that we circle around. Like, how do you all address that where you are in your program?
I'm gonna let Anna take that one.
So we here at Ingham County, we do not administer medication involuntarily. We cannot give shots without consent. We cannot give oral medications without consent. So at that point, like I was kind of saying, if it's to the point where the client needs medication and that's really the only thing that is going to help stabilize them, we would look at a petition or the ONC process. If they were in the jail and not able to safely manage themselves in here. Um, like some of you may know, the criteria to go to the hospital from jail versus from the community is very different. Just because we do have some safeguards in here, we have the psychiatrist, we have suicide precautions, we have padded cells, we have deputies here all day, every day. So the criteria is a little bit different, but yeah, we do not force medications here in Ingham County.
And what we can do too, Heather, and it gets in each ER is a bit different too, and there's debates about that. We could, if they were on the AOT and that was an issue, is consulting with the ERs and possibly having them transported over for those medications. And like Anna said, that's why we talked about it, it's still not perfect, and there is a lot of debate out there because technically the mental health code says, a mental health facility in jail, and ERs are not mental health facilities. So a lot of it is focusing on, and I think Jenny put a question there, that warm handoff. So it's not perfect, but it is like maybe more the warm handoff to get them connected. It's another avenue. So I hope that kind of helps, but that still remains a barrier. And I don't know until the code changes and it's specific to potentially being able to do that through the code. I think that would be very helpful.
Thank you.
I can answer Jenny's question as well. So wondering how the implementation started. I would say it started a few years ago. So my position here in the jail is really to help the jail with the SPMI clients who come in. So it kind of started with like really ill individuals getting out. So if they were just released, they are getting out in the jail is in Mason, so it's a smaller town, and we have one bus that takes them to Lansing. So a lot of our clients who are getting out cannot navigate that. They don't have the ability to get on the bus to make it to CMH themselves. So I really started advocating for like, hey, in the long run, this would also help you. These individuals need to get to the appointments, and in the long run, hopefully they would remain connected with CMH, and that would reduce the times they come back here. So it took, I've been working here for about 8 years, so I'd say it took about like 5 or 6 years to really kind of get some buy-in from the jail staff. So the relationships just kind of took time. And the other question, I think that communication and education with CMH and the jail staff So we are here to help the clients and help the deputies with the clients. So it unfortunately just kind of took time and a lot of hard work to kind of manage those relationships and communication and just have some buy-in from the jail too.
And I know we do yearly in-services too with our community partners, and we talk about some of the things that are a struggle. So really keeping the community involved and bringing everyone to the table and identifying each of those barriers. But I think the benefit and the thing, if I had to say anything about this program or how you bring it about, is having someone exactly like Anna that is going to push for it. You just have to have those advocates in your jail that are not going to give up and are going to push for those relationships. And like she said, it takes a really long time. Our relationship with our jail was poor, to say the least. But once they can see where you're at and why you're doing what you're doing and that we're not ignoring, I think that oftentimes, and I can imagine, jails aren't trained to deal, they don't, arrest people and, they're not trained to deal with mental health issues, and they're like, just get them out of here, get them out of here. And they think that mental health has all the answers. But when you can sit at the table and say, we hear your frustrations, we're as frustrated too, and we wish there was more, and coming together and seeing that we're at least trying to take the steps, whether it is with an AOT or whether it's simply a transport, like that's what my team does. It's like, great. If that's all we need to do to alleviate some crisis in the community by going to the jail at 3 o'clock on Mondays to pick someone up to bring them into an assessment, or bringing them dinner up in crisis services so we can get them connected to treatment, then it's a win in our minds. But you have to have these advocates. And I'm going to tell you, I am fortunate because Anna is, it's every day. She knows everybody in the jail. She's reaching out. She knows what has to be done. She's calling. And so that's how we make it work. But like I said, it's not perfect. There are people that get lost for sure.
Yes, thank you. So Barbara, it looks like Barbara Allen put a great question in the chat. Oh wait, did you already answer that? I'm sorry. Yes, I believe you already answered that. Sorry. So it looks like Julia also put in the chat. So who makes the decision about whether or not meds can be administered involuntarily in the jail? Is that a jail decision or a provider decision or both?
I guess here in Ingham County, it would be up to jail administration. I would say there would have to be the provider is just kind of prescribing it, so the jail administration would be the one directing our medical staff to give it to the individual. So it has never, since I've been working here, it has never been a thing. We haven't given meds involuntarily in the past like 10 years or so, I think. I don't know if Christy has.
In those situations, Julia, what we would do at that point at the jail, if the meds needed to be administered involuntarily and they were in a crisis, we would just use that AOT if they were on it to do a notification of noncompliance, and we would have them taken over to the emergency room, and whether the emergency room decided to do that or if they needed hospitalization. So that's also the AOT. We can look at it too as like kind of our safety net in the jail. Of that we're able to quickly intervene if we need to versus waiting. So we do the petition and then we got to wait and get the cert and all of those things, where if they're already on the existing AOT, then we can quickly do an ONC, get them transported to the right place. So yeah, that's one of the things.
Thank you, because I can imagine it's a really tricky situation and a hard thing to enforce and a tough decision to make. So thank you.
Absolutely.
I see Melissa has your hand up. Hey, Melissa.
Yeah, so I just wanted to give some info about how we do that here. So we have had success getting our jail to provide involuntary meds. And that came after years of attempting to have our partnerships with our ERs, as well as the sheriff's deputies being willing to wait and sit on someone in the hospital long enough for them to get an injection. That was a no-go. And so eventually they were able to get approval from, I believe, between the prosecutor's office and the sheriff's office, agreeable to say, like, we're not willing to do this transport, but if someone's already on an AOT, and they're suffering in the jail and they must remain in the jail because of other reasons, then they will provide that injection so that the individual can continue on with their treatment. So we've had some success there.
Melissa,
And I'm from CMH in Washington.
Melissa, did I miss it? Did you say your judges were involved in that too? Your probate
I believe
judges?
so. Yeah, everyone's kind of
Awesome.
on the same page that they're, that
That's
happens. And yeah, so I think that's been pretty successful. I know it was a slow go getting there, and I think we tried several different ways, but unless it was like either your deputy is willing to transport the individual to the hospital while they're still in custody, wait there until they're, assessed, and if then they might want to hospitalize them. And so, if they're unwilling to release them because that was the barrier, and they must remain in custody, then how else do we get this person care, right? If they're unsafe, if they're too unsafe to even leave the jail and they have to stay there. So that's been something that has been working out well.
Wonderful. Thank you so much, Melissa. Building these relationships can be slow going, but as we've said in this, in this space, once they do see it, or once you do get that buy-in, it can, start to evolve from there. If you have any follow-up questions of anything that was discussed here today or anything AOT related, feel free to reach out. We are here to help with AOT and to bridge knowledge gaps and be a supportive entity in that way. So, but otherwise, I hope everybody enjoys this sunny day. If it is sunny where you are, if it's not, I'm sorry. But thank you so much and have a great weekend, everyone.